Thank you so much, David, for the introduction. Hi, everyone. My name is Marina, and I'm excited to be presenting here today at the ECHO meeting. So today our objectives will be to discuss the use of pharmacogenomic testing for patients starting chemotherapy, describe the role of DPYD and UGT1A1 enzymes in the metabolism of various chemotherapy agents, and explain how to mitigate dose adjustments for pharmacogenomic polymorphisms. While there are multiple important pharmacogenetic markers in cancer therapy, some are more established while others have limited actionable guidelines. Today, we'll be discussing the more established pharmacogenomic markers in chemotherapy, specifically the role of DPYD in fluoropyrimidine metabolism and UGT1A1 for irinotecan metabolism. These agents are commonly utilized together in many gastrointestinal cancer regimens. For example, for the treatment of colon cancer, the FOLFIRI regimen is often used, which consists of irinotecan at a dose of 180 mg per meter squared, leucovorin 400 mg per meter squared, and a bolus dose of fluorouracil or 5-FU at 400 mg per meter squared, followed by a continuous infusion. We'll start off with DPYD impact on fluoropyrimidine. So approximately 5% of 5-FU is metabolized to active metabolites, leading to its cytotoxic mechanism, while 80 to 85% is catabolized by dihydropyrimidine dehydrogenase or DPD to inactive metabolites. The DPD enzyme is encoded by the gene DPYD. Mortality from 5-FU is low, ranging from 0.5 to 1%, and it can be estimated that for every 1,000 patients treated with either 5-FU or capecitabine in the US, 10 patients will die from treatment-related toxicity. In heterozygous DPYD carriers, phenotypically, these patients would be considered intermediate metabolizers as they have around a 30 to 50% reduction in DPD activity. And for homozygous DPYD carriers, these patients have the poor metabolizer phenotype as they have severely diminished reduction in DPD enzyme activity, ranging from 75 to 100%. As there's this reduced enzyme activity, both intermediate and poor metabolizers have increased exposure to 5-FU and 5-FU toxicity, including GI toxicity such as mucositis and diarrhea, myelosuppression, cardiotoxicity, neurotoxicity, and hand and foot syndrome. There are four common DPYD variants listed according to their nucleotide changes. All are relatively rare to occur in the heterozygous state and are even more rare as homozygous or compound heterozygous states. Compared to wild-type patients, those with the nucleotide changes C.1236G to A or C.2846A to T have around a 25% reduction in DPD enzyme activity, and those with the STAR2A or STAR13 genotypes have around a 50% reduction in DPD enzyme activity. Many studies have shown that patients with these genotypes have a significantly higher incidence of grade 3 adverse events from 5-FU compared to normal metabolizers. The probability of being an intermediate metabolizer is less than 5% and is mainly found in patients of European, Sub-Saharan African, African American, and Central South Asian ancestries. And comparably, the incidence of being a poor metabolizer is extremely rare at rates of less than 0.1%. Guidelines for dose adjustments based on DPYD polymorphisms are primarily based off of the 2022 Clinical Pharmacogenetics Implementation Consortium, or CPIC guidelines. Briefly, these guidelines assign an activity value of 2 for normal metabolizers, 1.5 or 1 for intermediate metabolizers, depending on the alleles, and 0.5 or 0 for poor metabolizers who are at extremely high risk of toxicity. Those with an activity score of 2 will receive standard fluoropyrimidine dosing. Those with an activity score of 1.5, CPIC recommends reducing the starting dose by 25 to 50%. And notably, this is an update from their 2018 guidelines, which recommended an initial 50% dose reduction for all intermediate metabolizers, no matter the score. For those patients with an activity score of 1, they recommend reducing the starting dose by 50%. And finally, those with an activity score of 0.5 or 0, they suggest avoiding fluoropyrimidines and switching to an alternative agent. Many studies have looked at the impact of DPYD pharmacogenomic guided dosing adjustments in reducing the adverse events with fluoropyrimidine therapy. In one study that prospectively screened over 2,000 patients with GI cancer that were intended to start on fluoropyrimidine therapy, these patients were largely Caucasian and were screened for the DPYD STAR2A allele. Only 1.1% of these patients were found to be DPYD STAR2A heterozygous, meaning that these patients were intermediate metabolizers and they received a median dose intensity of 48% 5-FU dosing. In looking at adverse events in the STAR2A heterozygous patients treated with 5-FU therapy, those who received the genotype-guided dosing in the current study compared to those who received full dosing in historical controls had a significantly lower incidence of grade 3 or greater hematological toxicity, gastrointestinal toxicity, and drug-induced death. Another study who included over 1,000 majority Caucasian patients also intended to start on 5-FU therapy. 8% of these patients were found to be heterozygous DPYD variant allele carriers. And this study actually followed the current CPIC guidelines by doing a 25% dose reduction for those with an activity score of 1.5 and a 50% dose reduction for those with an activity score of 1. What they found was that the relative risk for severe fluoropyrimidine-related toxicity was 1.31 for genotype-guided dosing compared to 2.87 in the historical control for the DPYD STAR2A carrier, and no toxicity was found in the c.1679T to G carriers. Therefore, for those who received the 50% dose reduction, they concluded that this was adequate to prevent grade 3 related toxicities. However, for those who received the 25% dose reduction for the c.1236G to A and c.2846A to T, this study didn't find that a reduction in toxicity risk comparable with that of patients who were wild type. For example, for the c.1236G to A, the relative risk in the historical cohort was 1.72, and in this study, it was 1.69, showing that the toxicity risk was still increased even when applying that 25% dose reduction. For the c.2846A to T, the risk of severe toxicity in the meta-analysis was 3.11, which decreased to 2 after the 25% dose reduction. However, this study noted that this relative risk of 2 was still increased compared with non-carriers of this variant. Therefore, overall, this study concluded that a 50% dose reduction was adequate for those who received it, but a larger dose reduction of 50% instead of 25% for those other alleles requires further investigation. The next pharmacogenomic chemotherapy relationship we'll discuss is UGT1A1 and irinotecan. So irinotecan is a topoisomerase 1 inhibitor that results in DNA strands breakage. It has severe toxicities listed as box warnings, including both early and late stage forms of diarrhea, as well as severe bone marrow suppression. It's metabolized by carboxyl esterases to its active metabolite SN38, which itself also has topoisomerase activity. And SN38 is further metabolized by UGT1A1 to inactive glucuronidated form SN38G that's excreted into the bile. Patients are at higher risk of toxicity, specifically when they have more concentration of the SN38 metabolite. The reduced UGT1A1 enzyme activity also will therefore lead to increased concentrations of SN38, leading to further risk of toxicity. That reduced activity is found in patients with the STAR6, STAR28, and STAR37 variant allele carriers. Compared to normal metabolizers, those who are heterozygous carriers or intermediate metabolizers have around a 30% reduced UGT1A1 activity, and homozygous carriers or poor metabolizers have around 70% reduced UGT1A1 activity, leading to that higher risk of toxicity due to elevated irinotecan concentrations. The STAR SAR28 allele frequency is common in patients of European and African ancestry, while the SAR6 allele frequency is rare in those populations and is more common in the East Asian population. But overall, being homozygous for either of these alleles is relatively rare. There are many guideline recommendations in regards to irinotecan dose adjustments based on the UGT1A1 polymorphisms. CPIC is the primary guideline utilized in the US. However, they do not have a formal guidance to dose adjustments. Meanwhile, the FDA recommends that for those patients who are at high risk of neutropenia, to reduce the starting dose by one level and modify the dosage based off of that tolerance. The Dutch Pharmacogenomic Working Group recommends that for patients who are homozygous for the SAR28 allele, these patients should receive a 30% reduced irinotecan dose. And for the French Pharmacogenomic Working Group, they recommend an initial dose reduction of 30% or more for doses less than 240 mg per meter squared and avoidance of doses that are greater than 240 mg per meter squared. While CPIC does not have formal guidelines, they do recognize that the UGT1A1 irinotecan pair is significant enough that genetic information should be used to change prescribing. The evidence for UGT1A1 guided dose adjustments comes from more rare prospective studies. In this one study assessing 350 Caucasian patients intended to be treated with irinotecan-based therapy, of these patients, around 9% were considered to be poor metabolizers as they were homozygous allele carriers, and they received a median 70% dose intensity of irinotecan. Compared to the UGT1A1 variant allele carriers who received the full dose of irinotecan and historical controls, those who received UGT1A1 guided dosing had significantly reduced incidence of febrile neutropenia in the first two cycles, being 7% compared to 24%, along with reduction in grade 4 neutropenia, 13% compared to 56%, chemotherapy-related hospital admissions, 13% compared to 42%, and a numerical decrease in grade 3 diarrhea at 10% compared to 22%. Another study that did a model-based clinical simulation in patients with metastatic colorectal cancer who were UGT1A1 poor metabolizers. This study compared patients who received a 25% dose reduction in irinotecan versus those who received the full dose with prophylactic GCSF to prevent neutropenia. Between these groups, they found a similar reduction in neutropenia from 45 to around 17 or 18%. However, noted that there was no reduction in diarrhea in those who received the standard dose with GCSF group compared to those who received the 25% dose reduced irinotecan. So therefore, there's many different strategies in dose adjusting irinotecan for UGT1A1 polymorphisms, as well as the strategy to prophylactically administer GCSF to prevent neutropenia. Overall, in conclusion, we know that the DPYD and UGT1A1 testing is an important factor to weigh the risks and benefits of fluoropyrimidines and irinotecan respectively. Clinical decision-making is necessary in the setting of delayed pharmacogenomics results, and we know that clinical decision-making is also necessary to prevent adverse events from these chemotherapies. And finally, guideline recommendations may vary in regards to dose adjustments for polymorphisms, so pharmacy expertise can aid in consolidating literature and applying genome-based guided dose adjustments. So that is all I have. I'll take any questions in the meantime.